Good evening, everyone, and welcome to our Oral Health Inclusive Practice and the Relationship Between Dentists and Pharmacists webinar. My name is Nicole Radford, and I'm one of the project managers for the Supporting People with an Intellectual Disability to Access Health SPIDER project, and I'll be the facilitator for this evening. Alongside me is Kerry Robinson, project manager of the SPIDER project, and Katrina Pilbeam and Erin Crimmins from the Workforce Development Team at the Western Victoria Primary Health Network. I'd like to begin by acknowledging the traditional owners and custodians of the lands and waterways from which we are all zooming in from today. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and I wish to extend that respect to any First Nations people connecting in today. We commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations peoples and organisations and will work together on closing the gap. Just a little bit of housekeeping. The majority of our webinar events are recorded and freely available on our PHN Learn YouTube channel, and Erin will put a link in the chat to access our recorded webinar events. I have the upcoming webinar events on the screen, and you can register for these events on our website. Erin will also pop that link into the chat for you. Please make note of the West Vic PHN Health Pathways relating to the topic of intellectual disability that's on the screen at the moment. If you have entered this webinar not displaying your accurate first and last name, can you please type your full name into the chat box? Only admin will be able to see this, and this will ensure that we can issue you with a certificate of attendance. For this evening's webinar, all participants will remain on mute. If you have any questions, please type them into the Q&A box, and I will ask them on your behalf to the presenters during question and answer time. Any unanswered pre-submitted questions or those asked during the session will be answered, and we can send that in the post-session email. There is a link in the chat box to complete the survey after the webinar, and we will show this slide again at the end of the presentation. We have some really great presenters lined up for this evening's webinar. We have Dr. Trudy Lynn, Young Australian of the Year, South Australia 2022, Special Needs Dentistry Specialist, Certified Mindset and Leadership Coach, Keynote Speaker as well. Associate Professor Warren Shnider, Registered Specialist in Special Needs Dentistry, Head of the Integrated Special Needs Dentistry Unit at the Royal Dental Hospital of Melbourne and Specialist in Private Practice, and Dr. Andrei, Tutoveanu, Dentist, Pharmacist, Lecturer, and Founder and Principal of Mosman Dentistry. For this evening's webinar, unfortunately, Dr. Trudy Lynn was unable to attend in person, so we're going to watch a pre-recorded presentation she has kindly prepared for us. Katrina will load this for us now. Thanks, Katrina.
Great to be here. So as Nicole mentioned, I'm a specialist in special needs dentistry. So my passion is looking after people's oral health care for people with various types of disability. But before I start off my presentation, I would like to start by acknowledging the traditional owners of the land from where I'm speaking from, which is in South Australia, the Gunner people, and pay my respects to their elders past, present and emerging. So the other thing I'll mention is that Nicole is going to be taking some screenshots of my presentation slides. So if anyone would rather not be in that screenshot, then please feel free to turn off your video. So I thought a good place to start would be to answer this question, because usually when people hear that I'm a dentist, the first question they ask is, why? Why would you want to go into oral health care? And after answering this question many times over the course of my career, I've managed to boil it down to one simple reason. And that is because I believe in inclusion. I believe that every person matters and every person deserves access to live to their true potential. And I know that oral health is such an important part of people being able to access true inclusion and be able to fully participate in society. And I think we all understand this to some degree, because what's one of the first things that you notice about someone when you first look at them? It's their smile, right? If they're not wearing a mask. So your smile is so much more than just a facial expression. It's the gateway to connection, to feeling included, and the self-confidence to be able to live to your true potential. And I learned this because my father, he had this condition called tetracycline staining, which stained his teeth black just like this. And I saw how his smile had so much impact on his entire life, from excluding him from being able to get the jobs that he wanted. He was rejected from job interviews based on how he looked and not on his credentials. He was then judged in social situations, and that had a huge impact on his self-esteem and his confidence. And so that's why I made it my mission to create an inclusive society where every person can eat, speak, and smile freely. The way that I ended up specializing in special needs dentistry was from drawing upon more of my family's lived experience. So this is my youngest brother, Aaron, who has mild intellectual disability and autism. And seeing the journeys that he went through and the challenges that he faced, all the barriers that presented from clinical environments that made it difficult for him to access oral health care is what led me to now commit to specialize in the field. So I'm actually one of only 25 specialists in special needs dentistry in the entire country. So we're kind of like an endangered species, especially when you contrast that with the current statistics of 4.4 million Australians who are living with a disability. So you can see that there are some states where there is an uneven distribution. Some states don't even have a specialist available, and we're quite stretched across the public and private sectors. So I have worked in both public and private settings at the special needs unit at the dental hospital for almost 8 years, and now aligning with my passion for inclusion and breaking down the barriers to accessing care, I actually spend most of my time now working in a mobile dental service called Respect Dental, where we visit people's homes, residential care facilities, and also supported independent living facilities, so that we can provide access to care to people who otherwise would be excluded from attending a hospital or clinic. So many of the patients I do look after include people with autism who may find it extremely distressing to attend a hospital environment because of the noisy waiting rooms, bright lights, strange sounds and smells. And then unfortunately, they end up being assessed for requiring something like general anesthesia. But by bringing the services to their homes, where they're in a familiar environment, they have access to their sensory tools and toys, we can provide this truly person-centered care and inclusive oral health care without them needing to be put under the risk of general anesthesia. So the photo on the slide now shows our mobile dental unit. It's just like having a mobile dental chair with me. It's got the same motor handpiece that I would use in a dental surgery, and we also have a portable x-ray unit. So we cart around quite a lot of stuff with us every day, but people are always very amused when they hear one of the things on my checklist in the morning is to put my knee pads on, because I do spend quite a lot of time getting down to my patient's level, especially if they're in a wheelchair. And I picked up the skill early on of being able to use the foot pedal with my knee. So that was a little bit about me and my background. What I'd like to share with you today is the impacts of oral health, and in particular, some of the data that's out there about the oral health of people with intellectual disability, what contributes to that, and then how we can help manage and reduce the barriers that they face to oral health care through oral health promotion. So let's start by asking the question of why oral health care is so important. So one of the objectives that's identified in the roadmap for improving the health of people with intellectual disability includes improving their oral health as a central requirement for their general health and their overall well-being. And it makes sense, doesn't it? Because oral health is an essential part for general health, given that everything enters your body through the mouth. And the health of your teeth and your gums really affect the ability to chew and therefore your nutrition, which is, as we all know, a very essential part of being able to have good overall health. There is also a lot of literature and research that shows that because the mouth is a portal into the body for harmful bacteria, it is well established that oral health is linked with the following general health issues, including heart disease, oral cancer, diabetes, stroke, lung conditions, and also adverse pregnancy outcomes like low birth weight. But the importance of oral health care goes beyond the overall health impacts. As we spoke about before when I shared my father's story, oral health is important for speaking and smiling, which then also has an impact on your self-esteem, the way you see yourself, your self-confidence, and your mental well-being, which then has a flow-on effect to impacting your ability to socialize, to connect with other people, and also to then access education and employment. So it's like your mouth is the gateway to your body and therefore your overall health, and your smile is your gateway to being included in society. And the oral health needs of people with disability are greater than people in the general population for a number of reasons. This might be because of comorbid medical conditions, conditions that affect sensory sensitivity, such as the case of my brother Aaron, the physical conditions that might impact their ability to clean their teeth, maintain a healthy diet, and also to cooperate with dental care. And this is reflected in the literature, which consistently reports that people with intellectual disability have higher risk of decay, gum disease, they have higher rates of untreated disease, which shows that they're not able to access care, and they're more likely to have unaddressed dental pain, as well as higher than average tooth loss. So not only do people with intellectual disability experience higher disease risk and burden of disease, they also face more barriers in accessing the care they need to address that. So now I've created a bit of a conceptual flow chart to show some of the more the impacts of dental disease and then how they all interrelate and compound on each other. So this is a bit of a busy slide, so bear with me here. Dental disease affects the ability to eat, can cause pain, and also affects appearance. And then the impact on eating ability can lead to poor nutrition and also general health, which then leads to polypharmacy, the prescription of various medications to help manage those various health issues. The pain from the dental disease also leads to medication prescription, where there is lack of appropriate access to oral health care. And the dental pain can also affect a person's behavior, which is their way of communicating pain, which without treating the source of dental infection can also then lead to the unnecessary prescription of sedative medications and contribute to that polypharmacy. The effect of dental disease on appearance then affects a person's socialization as well as their mental health, which can also be exacerbated if they have untreated dental pain. And then again, the mental health impacts can then lead to prescription of unnecessary medications. All of this then leads to the use of restrictive practices and diminished communication and agency for the person who is experiencing the dental disease, which then ultimately limits access to opportunities and their rights to decision making. And then to top it all off and bring it back full circle, the polypharmacy then increases their risk of further dental disease because many medications end up causing dry mouth. And so this creates a vicious cycle, which illustrates the importance of people getting timely access to intervention as well as preventative dental care for their oral health. So what are the main factors that contribute to poor oral health? There is a lack of regular daily oral hygiene, consumption of sugar, tobacco, and alcohol, and then finally, a lack of access and availability of services. So this can include a lack of access to specialists, access to inclusive oral health care services such as domiciliary care or care that's provided in the person's home, as well as the affordability of dental care and also lengthy waiting periods for public dental care. And so we can break these up into two groups, where the oral hygiene and the diet are modifiable factors which can be addressed through empowering people with intellectual disability and their caregivers. That is separate to the systemic access barriers and barriers in the workforce. And so this is where oral health promotion has a really important place. And why I'm a passionate advocate for empowering people with intellectual disability, as well as those that support them, to work on these modifiable factors. Using a relational model where the responsibility is shared between the person with disability to maximize their agency, but then also including the people who help support them. So I believe that oral health promotion should be extended to people with disability, their caregivers, dentists, individuals that work in the disability sector, and all other primary healthcare providers, which is why it's so wonderful to be able to share all of this information with you all today. And so it's so important to be raising awareness on these bidirectional impacts between oral health, general health, diet, and nutrition. And this is really shown by this diagram here, where we know about the interrelational relationship between oral health, diet, nutrition, how that then affects general health and well-being, and how if one of them isn't addressed, then it can start to compound and make the other one worse. And all of these factors are then influenced by a person's personal factors, such as if they have intellectual disability, which then puts them at higher risk of certain disease, as well as environmental factors, which then create barriers to them accessing the care they need. And so I'd like to highlight one of the studies which demonstrates the huge health inequities which is faced by people with intellectual disability specifically. One of them being the fact that Australians with an intellectual disability are dying prematurely compared to the general population. And the leading cause of their premature death is a respiratory disease, 50% of which is caused by aspiration pneumonia. And aspiration pneumonia is caused where the germs or the bacteria that builds up under the teeth are breathed into the lungs, and that's what causes the infection. And that is what leads to their premature death. So daily oral hygiene for people with intellectual disability isn't just about improving the quality of their life. It goes beyond that to actually affecting the length of the life itself. And so with the information I've shared with you all today, I really encourage you to be advocates for the oral health of people with intellectual disability and help me spread the message that brushing teeth saves lives. Thank you for your time.
I'd just like to acknowledge that Dr. Trudy Lynn's presentation had some really excellent content, and in particular, I really appreciated the flow chart showing the interrelation between all of the different factors that impact oral health and overall health and well-being. I'm now going to hand over to Associate Professor Warren Shnider to add some additional commentary following Dr. Trudy's presentation. Over to you, Warren.
Thank you. You can all hear me and see me clearly? Great, thank you. Thank you to Trudy, who's provided you with some excellent material. I just wanted to follow on from her excellent presentation. Some of the points that she raised are very interesting when I think about my experience working with people with disability over the last longer period of time. And that point about the fact that people with intellectual disability compared to the rest of the Australian population have poor oral health. When we think about individuals that we work with and we care for and we're responsible for, we know that there's a group of people who have got pretty poor brushing habits, and they've also got a poor diet, yet they seem to have pretty good oral health. And there's another group of patients, people who have got intellectual disability, and they've got very good habits and brush every day, and they've got a pretty good diet, yet they seem to have pretty poor oral health outcomes, lots of oral disease. And, you know, you've got to think about why that might be on an individual level. I understand we're down in the weeds, but there's a couple of things that are worth thinking about. I guess the first thing is obviously individually, we're talking about some variation in host factors. And probably the quintessential example would be somebody like somebody with diabetes. And their immune response to periodontal disease, gum disease, is going to be not as effective as people without a poor immune response. And typically, if lots of studies have shown that somebody who has Down syndrome compared to people with similar intellectual disability, their periodontal disease, their gum disease is worse because of that host factor, because of their immune response. So we can understand that some people have got significant host factors that make their oral disease far more devastating. But there's also another thing. There's another big component that is a variable that can be changed, and that is your advocacy. So when I started practice a long time ago, there was an institution called Kew Cottages. They had 3,500 patients there. Most of them had mild and moderate intellectual disability. And when I went to England, I was thinking about these institutions, and it was the end of the Thatcher years in the 80s, 1980s, when Margaret Thatcher and her government were deinstitutionalising people with disability, particularly mild and moderate intellectual disability. What happened was that when they were institutionalised, they had very well controlled diets. They were provided with toothbrushes and fluoride paste, and they were forced to go for regular dental checkups and access to dental care. So when Thatcher and her government brought all those people into the community, and we did in Australia in the 80s as well, for a community that's more psychosocially acceptable, of course, we're going to have people in our community with disability. It makes sense. But in fact, in terms of access to health and access to prevention, those people in the community are far more vulnerable. They may not have advocates, they may not have voices, they may not have access to care, and certainly it's not controlled. Yes, they have choices, but some of those choices may not have the best support to make those choices. And so over that period of time, from the 80s to now, the incidence of oral diseases as a population increasing because of that poor advocacy. So if you have something to take home from this conversation, you are at the vanguard. You are the people that are most able to make that advocacy change for people with intellectual disability to access care and to access prevention. So please use that information that Trudy has provided to advocate for the people that you work with, that you live with, and improve their access to care. Otherwise, they're in the community, and some of those choices might be inadvertently increasing them to vagaries of oral disease. Thank you.
Thanks so much, Warren. Really want to say thank you for the extra comments that you've added, and also really highlighting the role of advocacy. I think that's such an important message to be sharing today. So thank you.
Thank you.
I'm now going to hand over to Dr. Andrei to share his presentation and share the slides. Perfect. We just can't hear you yet, Dr. Andrei.
There you go.
Perfect.
So it's been a pleasure listening to the other two colleagues discuss some really crucial stuff regarding the topic tonight. So it was very insightful, and I guess part of the aspects that I'd like to contribute to is more so the interprofessional collaboration amongst dentists and pharmacists alike. And I feel, you know, it's an aspect that a lot of dentists may not be as familiar with. A lot of pharmacists may welcome the relationship and the communication, but it just seems not to gel as well, purely out of two professions not being as tight and not being, I guess, taught in university is how to sort of approach each other. But I definitely feel it's a synergistic relationship that hopefully I can expand on and share with you. I guess the first thing is I really do like this quote by the great Albert Einstein, because it does sort of signify that we're always students of life, and we always keep learning. And you know, as a profession, I think it's very important to be collegiate with our whether it's our medical colleagues, our pharmacy colleagues, our dental colleagues, and basically try and learn as much as we can to upskill each other, because at the end of the day, we have a very unifying theme in providing best patient care and management. And I feel hopefully this presentation today would inspire you and encourage you to sort of reach out, especially from a pharmacy point of view, reach out to our dental colleagues, and from a dental point of view, reach out to our pharmacy colleagues. So I think this slide, basically, I just sort of want to summarize a little bit of what we've already known coming into this presentation. I guess it's targeted towards our primary health physicians and our health professionals. in order to sort of bridge a collaborative and collegiate relationship, but also focusing on perhaps the population that seems to lack as well, as the other two presenters mentioned, with facilities, etc., and hopefully bridge that gap, but also allow us to increase our space of learning, increase our upskilling across the disciplinary aspects as well. So let's look at some of our learning outcomes. I guess what I'd like to do is explore the current relationship between dentists and pharmacists, and perhaps look at the main roles and responsibilities, but also each of their strengths and weaknesses, because I feel that this is a perfect example where each other's weaknesses can be swapped and become each other's strengths as well. And obviously touch on why I think the upskilling and that collegiate collaboration is important, again, because it's patient-centered. And perhaps we can sort of explore a little bit together what I sort of would propose as the new models for our interprofessional collaboration, and how maybe we can kick them off, whether you're a practitioner or our healthcare professional in the country versus the metro city area versus a coastal town. It makes no difference. It's the same ability, same protocol to follow. So let's look at perhaps our dental colleagues first, and understand that, look, most dentists, and I can attest to this, most of them that come to my lectures at the ADA, etc., and I do teach about pharmacology and therapeutics and drug interactions and indications, they themselves acknowledge their lack of pharmacological and prescribing ability. And they welcome new upskilling, etc. So that's something that you should know. I think a lot of the core topics surrounding this leads from the way we get taught, obviously, all our investigations, all our protocols, our procedures, the time we need to spend upskilling ourselves with diagnosis, proposing treatment options, and then their associated alternatives. That's what we end up becoming proficient in. And obviously it doesn't leave a lot of time to even understand a lot of the basics of what pharmacists would consider basics, obviously being the drug specialists, but then obviously having even a more intimate appreciation of pharmacology and prescribing fundamentals, let alone excelling in it. So I think also building that deeper relationship with a local community pharmacist really will help bridge this gap, these voids that dental practitioners have in their therapeutic knowledge. Looking at the core aspects to consider, basically assessing medical histories. The different medical histories I see colleagues do within the dental profession differ substantially from something very brief to something very comprehensive. Understanding drug doses, etc., really does make a difference, let alone understanding the pharmacodynamical considerations of patients and their host issues, etc., drug allergies. So that's something that I feel would most benefit our dental colleagues from bridging that relationship with our pharmacy colleagues as well. A little bit more on that. So, the multiple medications, particularly antibiotics prescribed in dentistry, there's numerous ones that go out of stock for weeks or months at a time, and it sort of catches dentists out. And this is a perfect opportunity to be able to have that ability to confirm which drugs are in stock, to confirm which classes the manufacturer may be out of stock, so we know how to substitute. And I guess a pharmacist and our pharmacy colleagues are particularly have the ability to particularly understand the differences between allergies and intolerances. These are very commonly misdiagnosed. Understanding an allergy is in fact an allergy, not an intolerance, whether it's a rash as an allergy or versus more of a gastrointestinal issue. It does not make the person necessarily allergic if they have that gastric issue, is what my point is. Having an appreciation of drug brands versus generic, coming from a pharmacy background, of course, we do have an appreciation of the filler versus excipients, etc. And this, having the active drug and understanding that there are other fillers or excipients in the actual compound product, it could actually very well be the allergy or the intolerance could be coming from that. So it's not the actual active drug. And this is a very common thing that a lot of practitioners may get wrong. So it's literally swapping brands, not necessarily labeling that person allergic to that active compound. In other words, actually being allergic to amoxicillin itself. Having appreciation of, combinatory therapy, so understanding combining medications together, or the need to titrate the actual dosage level is a major difference, to then needing to perhaps substitute that type of antibiotic or non-steroidal anti-inflammatory or antibiotic, or actually terminating it and ceasing that class of drug altogether. Then we sort of move on to having more of an appreciation of compounded products. Pharmacists are revolutionary at being able to compound medications that may not even exist on the market, or making it very palatable for kids, infants, or this is a particular of interest in special needs dentistry, where certain formulations, certain doses are required, but not in tablet form. Or sometimes not even in liquid form. Sometimes a lozenge needs to get made, or if a person has a lot of vomiting and based on various comorbidities or based on various diseases, particular enemas are made. So that is a very crucial role in all aspects of prescribing, especially for infant pediatrics, but also for special needs. Understanding and have appreciation as a practitioner to the addiction that's out there, or our contribution as prescribers to the addiction without us even being known. And also understand that there's a lot of doctor shopping that happens there. So what I mean by doctor shopping, for those of you who don't know, is basically patients that go in and out of medical centers or dental practices with various types of signs and symptoms to pain, and then basically getting scripts for opioids, etc., which further propagates addiction, drug abuse, and diversion of diversional behavior. Having appreciation of indications and contraindications. Is something really a contraindication, or is it more of a precaution? It's being able to balance those things with host factors and comorbidities, as well as other drug and disease interactions. I think maximum dosages versus therapeutic doses and toxic dosages are particularly important, and having an appreciation for those. Some particular medications may have what's called a narrow therapeutic window, which means the low dose is here, the high dose is here, and basically that window is quite small. So if things don't get monitored based on their dosage schedule, someone could either be subtherapeutic, in other words, would not get a therapeutic response, as in a positive response. If it was a pain-relieving medication, they would not get pain relief. Or if it was an antibiotics, they would not get resolution of that infection. Whereas the opposite end of the spectrum would be getting toxic effects from that. And a lot of that can be drug-mediated, or it could be genetic as well. And I guess having a good understanding of the side effect profile, is the side effect the patient getting from your medication, from another medication, from a host issue, or from an interaction of the medication you're giving or a medication they are? So, one of the questions that generally comes up in these kind of discussions is, okay, Andrei, how do we do a very concise medication appraisal? And I'm happy to go through that through the Q&A, because I think it's definitely worthy. But let's look at the pharmacy aspect. So like I said, pharmacists are born communicators. They you walk into a pharmacy, they're always able to help. It's not something that they actually bill for. So it's an expectation that's pushed upon them on their profession. So they're very willing and eager to discuss anything with patients, but definitely with providers as well. And I think they're at the forefront of pharmaceutical industry, which means they keep updated. They keep not only patients updated and their own profession updated, but they keep prescribers updated with new generics, new drugs, or even the converse of that, which I spoke of, which is out of stock medication. But at the same time, they also feel limited, having given lectures to them as well in societies, they also feel limited to what they can consider diagnosing as a dental scope. And I think this is the next point that really, I feel, will really hone in. Up to now, I've discussed on how pharmacists can sort of increase and upskill dentists, but I feel this is a really powerful tool, because patients coming into the pharmacy, there's nothing to say, I think, certain question that pharmacists themselves, they have the knowledge, they have the education, they have their ability to differentially diagnose with other aspects. Why wouldn't we bridge that gap from a dental perspective to a pharmacy perspective in making them and giving them the armamentarium to be able to ask the questions like, what's the onset of pain? what area is the pain and the duration, the severity, is the pain radiating, everything to do with the oral cavity. There's nothing to say that they can't be educated into, patient basically, these days in pharmacy, there's a special area where you do counseling, and it's very private. They can easily look inside a patient's mouth and be able to diagnose, well, look, I can see inflamed gums, I can see plaque, I can see a tooth that appears to be decayed based on the coloration, fractured teeth, etc. They would obviously be able to diagnose any pus or halitosis quite easy in certain individuals, or facial swelling. Empowering them to be able to triage, as I call them, just as triaging nurses do in the hospital, but having pharmacists be able to triage would be able to funnel the correct referral scheme towards dental practices versus medical colleagues. Not to say that that person wouldn't be taken care of, but I feel when a patient could be correctly diagnosed as an oral disease or an oral manifestation, whether it's tooth-borne or soft tissue bone-borne in the oral cavity, and correctly diagnosed to the dentist, it would save a lot of time for the person going to the medical colleague, perhaps getting something to try and alleviate the pain, which most of the time doesn't work because all the cranial nerves basically are so close to the oral cavity and all other manifestations, etc., and pressurized teeth, and also blood flow, the lack of blood flow to the area, it makes it very hard for a lot of medications to work without a procedure done dentally to the tooth or to the gum and bone. So that's an important point I'd like to pass on. I think some of the daily considerations that we see is, for instance, often patients will be taking medications for existing comorbidities or various dosage regimes. We need to understand that certain drugs are metabolized, and I know a lot of my medical colleagues will smile at this because we're very familiar with this, but understanding drugs are either highly metabolized by the liver or highly cleared by the kidney, giving them more medications that will, from a dental prescribing aspect or from a medical counterpart, giving them medications that may increase their liver toxicity or renal issues, could put someone in a potential hepatic crisis or acute renal failure. Understanding medication profiles is key to the daily prescribing habits that we have. When it comes to surgical interventions, and having an understanding of pharmacological knowledge really hones in on understanding the predictable inflammatory cascades and the pathophysiology of how these work in the body in order to basically get the patient outcomes through good monitored post-op phases. At the end of the day, the patient's going to be happy. So this is another reason why I feel upskilling each other from a dental to a pharmacy point of view and from a pharmacy to a dental point of view will not only empower those dentists or those allied health professionals / pharmacists, it will give rise to a better patient outcome. I think also using these strengths and weaknesses, I think will help build further relationships. I find that these professionals can have together. Again, the one thing I really want to hone in is a synergistic relationship, and I said that at the beginning of the presentation. I had it on my first page. I think it's important to look towards this next phase in our medication armamentarium and being able to provide healthcare to our patients, is understanding that it's a synergistic relationship, whether it's from a dental or pharmacy to a dental or medical as well. This is just a table that I got from one of our literature searches and understanding basically what I spoke about, but sort of highlights that some people are a bit more visual, really highlights the difference between a dental responsibility versus pharmacy responsibility, but they do have a merging effect. And I think the more we are able to empower ourselves to be able to do more, the more it's going to benefit the patient. So basically managing, for instance, pain is a big one that we're managing across the board with patients, whether it's in special needs or whether it's patients walking to pharmacy or our own dental patients. Managing mild, moderate, severe pain, both acute and chronic, has additional comorbidity factors that we need to consider. But at the same time, we're always concerned about the potential drug abuse, addiction, and diversion. I feel an appreciation for, are we preventing or treating an infection? Is it localized or spreading, or has it become generalized? Having those appreciations will allow us to really hone in on, are we using a prophylactic method, which is, in other words, preventative, or are we doing empirical, which basically means usual signs and symptoms will dictate a certain therapy, or are we doing directed methods? Directed methods and therapies are very seldom used in dentistry. It's more medical counterparts where we actually take biopsies and actually find out the root cause of the problem. So we're targeting antibiotic therapy, for example, for an infection. In dentistry, we don't always have time to do that. And we have to either lyse the area and diagnose if something's anaerobic or aerobic from a bacterial point of view and treat it. So again, having a stronger backbone and a stronger foundation through upskilling ourselves with pharmacy will definitely increase again. And I know I say this all the time, but it does increase our patient outcome. I think the other big thing that is, if I could really pass on from a pharmacological aspect, is having a better understanding in anticoagulants, antithrombotic agents, bleeding disorders, whether someone's immunosuppressed. I know we touched on with Prof regarding the immunosuppressed patients in special needs. With periodontal disease, as studies show, if your HbA1c is quite controlled, that's your monitoring aspect for the blood glucose and diabetes. If it is monitored and at a steady state, the literature has shown that those patients have the same risk factors for periodontal disease as non-diabetic patients. So it's looking at those certain categories in our population, one being special needs, patients that don't, for some of the reasons that both other presenters have communicated, don't have the ability or struggle, or there's certain things in our profession that we struggle being able to provide those aspects. So I think having an appreciation for this a lot more will aid, hopefully, in an awareness. And as the other presenter mentioned about advocacy, I think it's important. So first, we need to understand the situation, appreciate the ramification it's having, so then we could advocate to hopefully continue to change it. So I guess lastly is I just wanted to make mention of brief models, as I mentioned, the learning outcomes, and how we can sort of connect this this communication. Basically, as you can see from the pictorial representation, we have one dental practice talking to a pharmacy and vice versa. This is the first proposed model where we would have, and this is generally the rule, where one dental practice is in close proximity to a various pharmacy. Most of their patients go to that pharmacy in the area, and they're known to the pharmacist. They're able to pick up the call, and we get cross referrals. That's a very common one. Once we go to the second one, this is when we're dealing with, say, perhaps more in the country area, where we have a dental practice that has multiple pharmacies, and they're able, based on where people live, to be able to communicate with those pharmacies, and those pharmacies will also do cross referrals. But I guess the main one that I'd like to look at is the third model. This is to a different level, and this is where I'd love to see our own profession end up across the board. From an interprofessional collaboration, is where you have multiple pharmacies and multiple dental practices, and this has been shown to work with multiple medical practices, but it's being able to have the dentist or pharmacist triage the patient, and I'm referring mostly to the pharmacist, be able to triage based on what I mentioned for the pharmacist to upskill on based on the dental advice and counselling, triage the patient in-house, and be able to prioritize them, just like we do in the dental field, prioritize the order of priorities, we call it, into urgent, high or low, and then be able to cross-refer correctly. This will ease our time waiting in the queue for our medical counterparts. It would ease their waiting time as well. And it would also increase the access of healthcare on the correct referral scheme, so then patients can get the correct treatment, or most ideal treatment, I should say, at a faster pace. And this is basically the diagram. So there's a lot of arrows in here, similar to our first presenter, but it's basically showing how the more arrows implies the more avenues for patients to be correctly referred across and filtered across. And then having more of an appreciation, while as this is happening, as the triaging is happening, communication between the professionals is going at a lot more intimate and fast pace. And then we're able to obviously understand and have an appreciation more for drug-disease interactions versus drug-drug interaction, versus controlling disease states, and then obviously trying to work towards, based on this triaging technique, and work towards from treating to preventing. And I think if we use this model, there's nothing to say we can't achieve better patient outcomes. So I know that was a mouthful. I don't blame you for thinking that, and I hope this has somewhat painted a picture how important therapeutics are, the pharmacology is, and understanding the link between pathophysiology and disease states and interactions, and maybe how having an appreciation for that will lead into our professions having more of an appreciation and being collegiate and upskilling each other in a non-competitive way. I guess that is all is going to benefit our patients even more. So thank you for your attendance tonight, and I hope my presentation was just as valuable as the other fantastic two presenters.
Thanks so much, Andrei. Really excellent presentation, and I think you've shared some really important messaging around the interprofessional collaboration between dentists and pharmacists and the impact that that can have on overall health and wellbeing for patients. So thank you.
My pleasure.
Okay, you can stop sharing your screen now as well. Perfect. And I'll invite Warren to come back because we're going to step over to Q&A now. So I'll invite any attendees. If you do have questions and answers, can you pop them in the Q&A box? We did receive some questions in advance, so I'm going to commence with those questions. So one of the questions that came through was, what can private dental practitioners do to better care for special needs patients? So there's some sort of key things that they can do to provide better healthcare. And I'll just open it up. So Warren or Andrei, welcome both of you to respond.
Yes. I might jump in if I can. So a lot of practitioners, general dental practitioners, will have a cohort of patients with disability in their practice. And the great majority of those patients with mild and moderate intellectual disability will become familiar with the practice, with the people that are there, with the surroundings. Having a visual story about the practice before you get there, particularly having actual photos rather than a storybook. Having the people that are with that person show them what the experience is, what they're going to do, and basically model what the experience is going to pan out is a great way to do it. Start with something that's not in the clinic. Meet people in the car park. Meet them in the waiting room, but don't throw them straight into the tools and the equipment and the noise and the lights. Set the scene. Try and mask the bright lights. Have natural light coming into your clinic if you can. Distraction like music, flowers, pictures, soft lighting. You can have warm lighting. If you have a blue color on the wall, that's going to get people anxious, whereas warmer spectrum colors are going to make people more relaxed. My chair in the surgery at my private practice is mushroom colored, so it's a very neutral warm color. The other thing is that before you refer somebody off that you can't treat, if you're going to treat somebody, send them off to a specialist or an oral surgeon or whatever, make sure that you go through line by line with all that diet and prevention. Are they on fluoride toothpaste? Do they drink tank water without fluoride? Do they need a modified diet with poor oral clearance? Do they need to be assisted with their brushing? And certainly, what's the history of their dental attendance? Is this their first visit? They've been here a long time at another practice. And so you've just got to retrieve those records from where else it's been. And treat early. What happens is that if I could, I'd take everyone's cheeks away because no one looks in the oral cavity. So presentation is always really late. So if you had, for instance, a person with severe disability who was doubly incontinent and they soiled themselves, the intervention would be minutes away. But because the cheeks preclude good inspection in the oral cavity, you can have months to years of neglect before somebody actually does anything about it. So the first sign of changes of behaviours, particularly around cleaning teeth and eating, that's a red flag that something's going on. And even if you can't see anything, a checkup with a professional would be an advantage to that person who may not be able to communicate their discomfort. Andrei?
No, I think you covered everything really well. Not much more I can add to that.
Fabulous. I'll jump straight across to our next question because we had quite a few. So we'll see how we go in terms of time. So the next question I had is, how can health professionals structure the taking of medical histories? And what are some of the most effective ways to word questions about medical histories and medications?
You can kick it off, Andrei.
I think it's important having, a skeleton key like everyone has with their basic questions. But I think if I could label some really red flags that maybe we could, as a whole, elaborate more on, is when you ask people, you ask patients, that is, what medications are you taking, or are you taking any medication? Don't just stop there. Are you taking any medications? Whether over-the-counter medications, not just prescribed. Patients have an innate ability of thinking that when you're asking medications, it's only about prescription medication, otherwise known as Schedule 4. There's over-the-counter medication, which are S3 and S2. They're not familiar with that. But the moment you ask over-the-counter medications, they'll be like, oh, yes, I'm also taking this. On top of that, ask them any herbal remedies. Are you taking any herbal remedies? A lot of herbal remedies that can, react with bleeding issues, etc. A lot of medications that people take for health, for well-being, for mood stabilizers that are Chinese remedial medications. That they're not trying to withhold this information. They're not a health professional to be able to understand what you mean. So it's our responsibility, our duty of care, to make it very simple and very comprehensive for them to respond. Another point when we talk about allergies, as I mentioned in the presentation, don't just ask a patient, are you allergic to anything, Mrs. Smith? It's when they say yes to something, ask questions. So what exactly happens, Mrs. Smith? And they might say, I get a inflammation in the neck, etc. My lips swell up, my tongue swells up. That's an issue. If they just say, I've got a bit of a upset stomach, well, then you're most likely you're dealing with the intolerance, okay? So it's about making those differentiations there. Very equally as important, when they give you a list of medications, sometimes you're the provider that may be able to pinpoint if someone is double dosing on something. They could be on a generic and an original that they don't know, whether it's a non-steroidal, whether it's another cardiac drug, respiratory drug. You need to pick up on that. It's our responsibility. It's the famous saying that I always say in the presentations, where once we get that blue script pad legally, we are required to know all medications, all their connections, all their drug interaction, which is obviously not fair because we're not drug specialists. But we generally prescribe at best 3 to 5% of all medications as dental professionals. We don't venture out from, say, our amoxicillin, our Panadine Forte, our Bufrin, which is Nurofen. And if they've got an allergy to amoxicillin, we'll give them another medications. Or if they don't, if they've got any reflux, we just won't give them Bufrin, or if they react to asthma. So we don't really venture out at all, but we're legally binded by an appreciation for that. So it's something that we need to upskill ourselves on. So reiterating, going through the list that they give you and making sure that no double ups on medication. Knowing and having an appreciation of what you're giving, whether it's 3 or 4 different types of medication that you usually give, understand them intimately in how they can affect people that are on, say, a diuretic, and an antihypertensive medication, and the possibility of getting renal failure because you're going to load them up with a non-steroidal anti-inflammatory. It's called the triple whammy interaction. So I think having a more of an appreciation of the interactions and having our MIMS open. MIMS is a great tool that you can use. It's available in hard copy, but I'd really suggest you subscribe to the computer version, because what you can do, you can actually quickly input all the medications. Guess what? Pharmacists, yeah, we're good. We're specialists at knowing drugs, but even we have a foggy day and we can sometimes not connect the two. So we just put our medications into that table. It will literally spit out an interaction list. Not only will it spit out the severity of the interaction, it would spit out the evidence base, whether it's weak, moderate, or strong. So in other words, if something has a very strong evidence base to be highly toxic, well, there's alarm bells. So that's another point I would say. Another good reference I would use in conjunction with a medication review is the Australian Medicines Handbook. That's basically the Bible in pharmacy. We need to actually remember that from cover to cover. And it's Australian registered, which means all the drugs that are registered in Australia, a TJ approved, are in there as well. And it's very systematically written out from a drug class to an indication to contraindication to pregnancy, breastfeeding, what category it is, side effect profile. And guess what? It's got its doses is there. And it's got a little, at the bottom, it's got all the brand names and strength. So it's very easy. It comes out every 2 years. The other thing I'd mention in medication profiling is having an appreciation of have they missed anything out. You can't just assume. So what I like to do is I like to cross-reference them with their local pharmacy. Hopefully they go to the same one. You'll find the more elderly population like to stick to the same pharmacy, whereas the younger sort of crowd will just go to wherever they end up being. But at the same time, obviously, depending on their comorbidities and genetic state, there's generally less medication that the younger population would be taking, give or take. I think that's all that comes to mind. But Warren, did you have anything you wanted to add as well?
Oh, yeah, I'm just going to get on my hobby horse very, very quickly. Fluoride. Fluoride is a pharmacologically active ion, not in the organic side, but in the inorganic side. A lot of people, carers, families say, we don't want to actually have any artificial thing. We only want natural things, so we want fluoride-free toothpaste. Well, actually, fluoride is natural. And in your neck of the woods, Warrnambool and Port Fairy is naturally fluoridated water supply at the optimum level. So caries' risk in that population is fairly low compared to the rest of Victoria, where we have to actually add it. Fluoride is available in the supermarket, but in the pharmacy, there's an F3 at 5,000 parts per million, which is 5 times the strength. Now, if you have somebody with disability who is underweight and you're swallowing it twice a day, the pharmacist needs to know the concentration of the fluoride in what they're dispensing as F3 behind the counter and what they've got on the shelves. You've got to understand the toxicity of fluoride, and you've got to look at the client and whether they're swallowing and what their weight is. Fluoride was described in 1973 by the WHO as the cheapest, most effective way of treating the most ubiquitous disease on the planet, dental decay. We need to have fluoride. We can't afford to be without it. And the pharmacist has a responsibility to check and dispense correctly.
That's a very good point, yeah.
Thanks very much. I am mindful of the time. We've only got a few minutes left. So I will ask both Andrei and Warren if you've got any final key take-home messages for the people that are in the session today. What do you want those key takeaways to be?
I think there's a collaboration. My father was a pharmacist and my brother-in-law was a pharmacist. And I learned a heck of a lot about pharmacy. So I would encourage dentists to go into their local pharmacies, see what the products are, see what they're dispensing, and build that rapport face-to-face now that COVID's over, and vice versa with the pharmacists, because in particularly rural communities, that is the strength, that communication to get the pharmacological aspect of care right. We are churches, we cut because inorganic things, teeth, don't respond to a lot of pharmaceutics because they don't get into the teeth. It's only when we've got infections and pain that we really need pharmacological action. However, working in conjunction with pharmacists to understand where we come from, read oral and dental therapeutic guidelines, read about antibiotics and how in the great majority of dental issues, antibiotics are not effective. You have to cut the issue, not treat it with antibiotics.
Yep.
Thanks, Warren. Andrei?
I totally agree with everything you said, Warren. And just a little bit more of a spin-off from what you were saying then at the end with antibiotics, I find the lack of, I guess, knowledge from a dental point of view, that dentists that don't have that connection with pharmacists or don't have that strong pharmacological knowledge, they tend to overprescribe when you don't need to, just like antibiotics, like you said, building more antibiotic resistance, side effect profiles, etc. And then don't prescribe antibiotics at the high dose or the correct antibiotics when they need to, or do the first stage root canal, for example, when they need to, and just prescribe. So yeah, it really makes a difference from both ends in sound prescribing. So definitely, I agree with going in face to face, and as Warren was saying, country individuals, professionals are much more close knit, and it just comes more naturally to them than sort of the more fast paced areas. And I think we need to take a page out of their book to be able to build that rapport. At the same time, get into having some sort of subscription, whether it's MIMS or the Australian Medicine's Handbook, to have that as a resource.
Fabulous. Thank you so much, Andrei. I'm going to be wrapping up the session now. So I would also just like to acknowledge that Dental Health Services Victoria have developed an online module for pharmacists to introduce them to oral health. And it'll be a 3-part series of videos modelling client-pharmacist interactions. And it'll be available as CPD for pharmacists later this year. So some information is going to be popped into the chat. I'd like to ask everyone that's attended this session today to please complete the participant evaluation survey by the QR code or the link that's in the chat. And I'd like to say a very massive thank you to Trudy, Warren and Andrei for the excellent content that you've shared with us all. I think everyone's going to be taking home some really important information and lessons that they can implement in their day-to-day activities. So just want to say a very big thank you. Really, really appreciate your involvement.
Thank you for listening.
Thank you for attending, guys.
Thank you.